I'm delighted to invite on our next speaker to speak on research needs for public health and priorities for Pacific Health. We have Dr. Corina Gray, who is a public health physician, an epidemiologist, and a respected leader with extensive experience spanning over 15 years in public health, epidemiology, and health policy. She currently serves as the Director of Public Health at Te Whatuora as of May 5th, 2025. Little fun fact there. And is a co-principal investigator for the Manawataki Whatu Research Initiative at the University of Auckland. She said to keep it short, so she's going to come and speak very soon. But you can Google her after for more details and some fun facts. Please join me in welcoming Dr. Corina Gray. Whaftai.
Tēnā koutou katoa, mā luelelei, kia ora nā whakalofalahi atu, bulavanaka, mā loni, talofalava, and manuele vaiaso o Lingangana, Samoa. So I want to thank the organisers of today's symposium for bringing us together and for the opportunity to present today. I also want to acknowledge our distinguished guests and the Reverend for opening us in song and prayer this morning. I'd also like to acknowledge all our speakers who have and will be presenting throughout the course of the day. It's really wonderful to see the depth of Pacific research here in Aotearoa and in the region. I'd also like to acknowledge my heartfelt congratulations to Sir Colin for your well-deserved professorial appointment. I'm really looking forward to your inaugural lecture this evening, and as someone who has benefited from your support over many years, I feel immensely proud. So I've been asked to speak about Pacific health and public health priorities in Aotearoa, New Zealand. Now, there are a multitude of public health and Pacific health frameworks that we could use to think about and prioritise the different issues facing Pacific peoples in Aotearoa. This model, by Dyer and colleagues in 2022, is based on the Dahlgren and Whitehead model of health determinants. And I like it because it articulates different factors at many different levels that impact on individual and population health. Ultimately, our goal is to see thriving Pacific communities, healthy whānau, and successful individuals. At the highest level, climate change is obviously one of the most urgent public health issues facing the planet, having particularly significant impacts on Pacific Island nations, as Professor Donald has told us this morning. And I'm really looking forward to the launch of the Lancet report on climate change and health during our working lunch this afternoon. Another priority is ensuring that the places that people live, work, learn and play are healthy environments that support whānau to thrive, and that includes warm, dry housing, safe, healthy neighbourhoods, and environments that are conducive to optimal learning and working. For Pacific peoples, socioeconomic, commercial and digital factors play an important role in determining people's life trajectories and health outcomes, and we know that there are significant inequities in income, as well as education, employment and technological opportunities in Aotearoa. These and other factors contribute to differences in access to timely, affordable and high quality care, as well as an underrepresentation of Pacific peoples in the healthcare and research workforces. Addressing communicable diseases is also a priority, as well as pandemic preparedness and our ability to respond rapidly to outbreaks and other emerging public health issues and threats. And finally, we need to think about how we tackle the growing burden of non-communicable diseases and how we close the long-standing gap in life expectancy for Pacific peoples. But I'm not going to talk about all of these priorities this morning. Instead, I'd like to offer some reflections based on some of my experiences over the last few years. So my first reflection is that one of the greatest strengths of Pacific peoples is that we are part of transnational communities. Pacific peoples in Aotearoa maintain very strong links with our respective Pacific Island countries. This means that any major event in the Pacific will impact Pacific communities in New Zealand and vice versa. So this table shows 5 of the larger Pacific ethnic groups in New Zealand. The middle column shows the number of people living in that Pacific country, and the right-hand column shows the number of people identifying with that ethnic group living in New Zealand. And so the first 3 rows show the New Zealand realm countries of Tokelau, Niue and the Cook Islands, and the last 2 rows show Tonga and Samoa. So as you can see from the table, the number of people identifying as Tokelauan, Niuean and Cook Island in New Zealand are much, much higher than the number of people residing in those Pacific Island countries. And the number of Samoans and Tongans in New Zealand is very similar to the number living in Samoa and Tonga. This highlights the important role New Zealand plays in the health and well-being of Pacific peoples, not just in New Zealand, but on a global scale. The transnational nature of Pacific communities was well illustrated in 2019, when New Zealand experienced its largest outbreak of measles since 1997. Measles is an incredibly contagious illness with a reproductive number of 12 to 18, which basically means that each person with measles would, on average, infect 12 to 18 other people in a totally non-immune population. So in 2017, New Zealand had achieved measles elimination status, which means that measles does not spread within the country, and new cases only arise when someone contracts measles overseas and comes back into the country. Achieving measles elimination status in New Zealand was a historic public health achievement, but remains a challenge due to measles cases rising globally and vaccination rates remaining suboptimal, not just here in New Zealand, but around the world. In 2019, following multiple virus introductions into the country from returning travellers, 2,185 cases of measles were notified across the country, with the majority in the Auckland region. Pacific communities were disproportionately affected, with an incidence rate 14 times higher than the European population. Almost 40% of cases were hospitalised, but fortunately, there were no deaths. Sadly, this was not the case when one of the New Zealand measles cases inadvertently exported the disease to Samoa. New Zealand, a developed country with around 5 million people and a robust health infrastructure, experienced more than 2,000 cases and almost 800 hospitalisations, and our health system was severely strained. So we can only imagine how overwhelmed the Samoan health system was when this population of just under 210,000 people, with a fraction of the number of doctors per capita, experienced more than 2.5 times the number of cases and hospitalisations. According to official counts, 83 people, many of whom were babies, died. Needless to say, it was absolutely devastating, and there were lessons for both countries. One of the most important things New Zealand can do as a good Pacific neighbour and to protect our own population is ensure we vaccinate as much of our eligible population as we can to prevent ongoing transmission when cases are inevitably imported into our country. This table shows MMR vaccination coverage for children aged 1 to 5 years as of April this year. To achieve herd immunity, we need 95% of our entire population to be fully vaccinated or immune from previous infection. But as you can see, for children under the age of 5, we still have a long way to go to achieve that target. Furthermore, there are adults in certain age groups, particularly those between 25 and 45, that's some of you in this room, who had lower rates of MMR immunisation as children, and it's estimated that up to a quarter of people in this age group are not immune to measles, which creates a risk that measles could be spread through this group, who are also probably the group who are most likely to travel. So the health system is very focused on increasing immunisation rates among children, and research by Moana Connect found that the greatest barrier to childhood vaccination was not that families don't want to vaccinate their children, but rather the same access barriers we see across health services, including issues with transport and childcare, concerns about costs and eligibility, and the fear of exposing infants and young children to infectious diseases in the community and clinic. Their recommendations were to obviously address these barriers, as well as focusing on building trusting relationships with Pacific families and communities, taking time to unpack vaccination information and explore any concerns that families have, as well as growing the Pacific vaccination workforce. Which brings me to my second reflection, which is that we need to address access to health services at all stages of life. One of the most stark indicators of inequity in access to care is in the receipt of care during pregnancy. New Zealand operates a lead maternity carer system, which runs on the premise that pregnant people have a choice in who provides them with antenatal care. It's usually a midwife, but could also be an obstetrician or GP. Registering with the lead maternity carer in the first trimester of pregnancy means that people can access preventative and intervention services early on, giving them the best chances of having good outcomes during pregnancy, birth, and in the early neonatal period. For example, people can receive nutritional supplementation, screening for diabetes and syphilis, and are set up to receive immunisations such as for whooping cough later on in pregnancy. But for as long as we've been reporting on LMC registration, Pacific people have had significantly lower access to maternity care compared to all other groups, which directly impacts on maternal and perinatal outcomes. So this graph shows perinatal mortality rates by ethnicity, with Pacific babies having significantly higher risk of death compared to all other ethnic groups. Work by the Maternal and Perinatal Mortality Review Committee over many years has linked these inequities in death rates to lower rates of access to care, but still, registration remains low. Now, the reasons for these lower rates of access are likely multifactorial, but what we do know is that there are shortages of midwives in areas where Pacific communities are concentrated, and most notably South Auckland. In addition, of the 3,000 midwives in New Zealand, only about 100, that's 3% of the workforce, are Pacific, despite Pacific peoples making up 9% of the total population. And this brings me to my third reflection, the importance of growing the Pacific health workforce. So this table shows 6 different categories of healthcare providers in New Zealand and the percentage of that workforce that is Pacific. So if we keep in mind that Pacific peoples currently make up 9% of the total population, but only roughly 5% of nurses, 3% of midwives, doctors and pharmacists, and 2% of psychologists and dentists, it's clear that not one of these workforces comes close to having a representative proportion of Pacific peoples. Te Whatu Ora also does 10-year workforce forecasts based on the number of people currently in training. And these forecasts show that even in 10 years' time, the incremental change is nowhere near what we would need for proportional representation of the Pacific population. Pacific peoples would still only make up about 5% of nurses and midwives and 3% of doctors, pharmacists, psychologists and dentists. Why is this an issue? Well, there is a growing and increasingly compelling body of research that supports the effectiveness of cultural concordance among patients and healthcare providers. Studies show that when patients and providers share similar ethnic and/or cultural backgrounds, it can mean they share similar beliefs, values and experiences, and potentially a shared language, which can facilitate enhanced communication and trust, resulting in patients have a better understanding of their conditions and treatment options. It can lead to an increase in the number of providers in areas where there are underserved communities, thereby improving access to care. It can also reduce implicit bias and experiences of racism within the healthcare sector, which have been shown to negatively impact on health outcomes. And it's associated with greater patient efficacy, patients feeling more confident and knowing when to seek care and how to manage their conditions. And we need to do everything we can to address the equity gap for Pacific peoples, as evidenced by the significant and long-standing gap in life expectancy that we see in Aotearoa. So this graph shows trends in life expectancy over the last 20 years for Māori in red, Pacific peoples in blue, the colours have changed, Europeans in purple, and Asians in green. So life expectancy is often used as a way to assess the overall well-being of populations of people, and it's thought to be an indicator of the general living conditions, quality of care of the country, and access to proper nutrition. So the good news is that, like most developed nations, New Zealand is seeing an increase in life expectancy over time, which is a great thing. People are living longer. But unfortunately, the increase in life expectancy for Pacific peoples has not occurred at the same rate as other groups. And there remains a gap of approximately 6 years between Pacific peoples and Europeans. What's more, analyses published by Te Whatuora in 2024 show that there is a gradient in life expectancy by socioeconomic status. So people living in wealthier neighbourhoods can expect to live years longer than people living in socioeconomically deprived neighbourhoods. Many of you will be familiar with the New Zealand Index of Deprivation, which is a measure of the socioeconomic status of different areas in New Zealand. Each neighbourhood is given a score from 1 to 5 based on socioeconomic measures, such as the level of unemployment in the neighbourhood, the number of people on a benefit, or the number of people with access to the internet or a car. So areas in quintile 1 are considered to be most financially affluent, while those in quintile 5 experience the most socioeconomic challenges. So this graph shows life expectancy for Pacific peoples in the dark blue and non-Māori, non-Pacific peoples in the light blue by neighbourhood deprivation, so increasing deprivation along the x-axis. Note that in this graph, there's no life expectancy for Pacific peoples living in quintile 1 because there weren't enough Pacific peoples living in the least deprived neighbourhoods to generate an estimate. But if you look at this, the socioeconomic gradient in life expectancy is experienced by both Pacific and non-Māori, non-Pacific people, but Pacific peoples living in the least deprived neighbourhoods still have a life expectancy that's 2 years lower than non-Māori, non-Pacific people living in the most deprived neighbourhoods. So this tells us that the gap in life expectancy for Pacific peoples cannot solely be explained by socioeconomic factors that we can measure. It's like these slides have a life of their own. But neighbourhood deprivation is important, but it's not equitably distributed by ethnicity. So this graph shows the percentage of people by ethnicity who live in quintile 1 in green, all the way up to quintile 5 in purple. So across New Zealand, about 20% of people live in each of the quintiles. But as you can see from the graph, more than half of Pacific peoples live in quintile 5, and 75% of Pacific peoples live in quintiles 4 and 5, and these are the neighbourhoods that experience the most challenging socioeconomic conditions. Research has shown that people living in these neighbourhoods often don't have equitable access to good quality housing or safe spaces to walk and exercise. Conversely, they're often exposed to more environmental stresses, including pollution, excessive noise, more crime, and environments that are not conducive to good health. And that is why my fourth reflection is that we must support healthy environments. I've been really privileged to attend many, many community engagement events over the years, and a key message from communities is that they want agency over the environments they spend time in. Youth in particular have asked us, how can you expect us to be healthy when there are takeaways, alcohol shops and vape shops on every street corner? We must listen and amplify the voices of communities, find out what matters most to them and support them to implement their own solutions. This graph is from the Geospatial Research Institute, which looked at the number of vape stores by neighbourhood socioeconomic status. They found strong disparities by both area-level deprivation and ethnicity, with a greater number of vape retailers in the more deprived areas and in places with the highest proportion of Māori, Pacific and Asian peoples. Almost 30% of vape stores were within 400 metres of a school, and 97% were within 1,600 metres of schools. Some schools had up to 37 vape retailers within 1,600 metres, and some of the most underserved communities had up to 7 vape retailers within 400 metres of a school. Other research has found similar socioeconomic inequities in access to fast food and alcohol outlets. So why does this matter? Because the environments that people live, work and learn in matter. This graph shows trends in daily vaping by ethnicity from 2016 to 2023 for different ethnic groups, and the trends for Pacific peoples is shown by the yellow line. So over that 8-year period, daily vaping increased from less than 2% to 19% in Pacific peoples. In a recent report for Te Whatuora, researchers talked to people from different neighbourhoods about the impact of alcohol outlets in their area. Residents felt the visibility of alcohol outlets close to schools, alongside public drinking, normalised alcohol and contributed to underage drinking. Most residents felt alcohol supply, public drinking and intoxication negatively impacted their neighbourhoods, making them feel less safe. Many people reported avoiding parts of the area some or all of the time. Parents also restricted their children's activities due to safety concerns. For example, not allowing their kids to walk to school or play at the park. These reduced opportunities for children to walk, play and socialise with friends and just generally exert their own independence. Some people drove to other neighbourhoods to shop or exercise to avoid drinking locations, facing additional transport costs and reduced opportunities for exercise. In the health system, it's so easy for us to say, we're just going to educate people about healthy living. But individual behaviours are very much influenced and often very dependent on the environments we find ourselves in. But there are plenty of opportunities for action, and that brings me to my final reflection, making better use of population data to inform public health actions. New Zealand's Pacific population is actually very unique in terms of its high geographic concentration in urban areas, and particularly Auckland, Waikato, Wellington and Christchurch. According to Census 2023, 275,000 Pacific peoples, that's 62% of New Zealand's entire Pacific population, live in Auckland, and Pacific peoples make up 17% of the Auckland population. Now, this geographic concentration can sometimes be a negative, as we've seen with the clustering of unhealthy environments in certain neighbourhoods, and also where there are particular weaknesses or gaps in services, such as the shortage of midwives in South Auckland. But it can also be a positive, and as public health practitioners, we can use this information to better plan and target services that directly address differential access to the socioeconomic determinants of health and opportunities for Pacific communities to thrive. Auckland is a particularly good illustration of the geographic concentration of Pacific communities in certain areas. There are 21 local board areas in Auckland, shown in this map, which I just downloaded from the Auckland Council website. But, it's like these gremlins in the... Okay, well, sorry, but 2/3 of the Pacific population in Auckland live in only 5 of the 21 local area boards. 3 in South Auckland, 1 in East Auckland, and 1 in West Auckland. And this table shows those 5 local board areas, the number of people, Pacific people living in that area, and the percentage of people in that area that are Pacific. So, for example, there are almost 50,000 Pacific residents living in Mangere or Tahuhu, And of the people living in Mangere o Tahahu, 60% of people are Pacific. And similarly, right next door in Otara Papatoetoe, we have more than 42,000 Pacific people living there, and almost half of residents there are Pacific. This information is important for us to understand what areas we should be focusing on in order to maximise opportunities for Pacific communities, and in particular Pacific children, who will make up an increasing proportion of our future workforce. Now, in New Zealand, there are more than 400 secondary schools, but school roll data from Education Counts shows that you only need to go to 12 schools to find 25% of all Pacific secondary school students in New Zealand. So this table shows those 12 schools as of October 2023, the number of students on the roll of that school, and the percentage of the student body that is Pacific. So not surprisingly, all 12 of these schools are in Auckland, and they mostly correlate with the local board areas that we saw in the previous tables. So this provides us with a really important opportunity to be able to reach a large number of young Pacific peoples in their whānau and maximise our resources. And if we're thinking about equity and educational outcomes, we also need to ensure that these schools have access to high quality teaching and other resources, and value and reward their teaching staff in the same way all other schools do. So I'd like to leave you with a Samoan proverb and some final thoughts. Tautua nei mo se tai ao manuia, serve now for a better tomorrow. So I recently finished the book, Hidden Potential by Adam Grant, and there was one quote that really stuck with me. It's more important to be good ancestors than dutiful descendants. Too many people spend their lives being custodians of the past instead of stewards of the future. We worry about making our parents proud, when really we should be thinking about making our children proud. The responsibility of each generation is not to please our predecessors, it's to improve conditions for our successors. And what an amazing opportunity we have to do that with our research and in public health. Ngā mihi, nui kia koutou, whawhtai tele lava. Thank you very much.
Whawhtai te le lava, thank you very much. Ladies and gentlemen, that was your Director of Public Health at Te Whatuora, Dr. Corina Gray. Mahalo a pito.